Thank you for joining us in our Strategies of Success WebEx series today. This WebEx is entitled E&M Coding, the Undercoding Issue and How to Avoid It. My name is Carolyn Parker, and I'll be presenting the information on this topic today. Should you have any questions during the presentation, please feel free to submit them as you participate, and I'll cover them at the end of the presentation. The focus of today's WebEx will be the undercoding of services. That is, selecting a code that does not capture the true intensity or amount of work that actually is performed. It's true that overcoding exists as well, and also that services performed are underdocumented. But today I'm going to focus on undercoding. Upcoding was discovered in WebEx number 10. The information provided in this training module is not intended to be legal or medical advice. It is recommended that participants not rely on this general guide in structuring or analyzing individual transactions, but that professional advice be sought in connection with any such transaction. Nothing herein is the official position of Allegiant Creighton Health. When it comes to medical billing, undercoding is a significant problem that usually results from lack of knowledge and fear. When a doctor or doctor's office doesn't properly understand medical billing, they guess at the billing codes that should be using and stick to a very basic number of billing codes. When these billing codes are overused, they can trigger an audit that will result in illegal practices. So within this WebEx, I'm going to discuss undercoding as a billing issue, Evaluation of Management 101, the False Claims Act, identifying undercoding, benchmarking tools, how your EMR can help you, and auditing within your office. At a surface level, it appears that undercoding is better than overcoding. They are equally problematic because they will result in an audit. When an audit is performed, undercoding can stick out like a sore thumb because it is a very overused code, such as 99212. The undercoding will also cause financial problems for your practice. Doctors are entitled to earn the money that they earn, every bit of it. So if you're performing more work than a general checkup on your patients, but charging for a general checkup, you're only hurting yourself. Some doctors bill all of their office visits at a lower level, such as 99212. These doctors hope by doing this, they'll be able to alleviate billing complications. Unfortunately, this approach of billing does more harm than good to the financial well-being of your practice. First and foremost, when you generalize your coding like this, you're losing out on a lot of revenue, usually to the tune of about $100,000 each year. However, this isn't the only problem that this billing technique presents. If you use a single lower-level code for all of your office billing, you're going to run into problems if you face an audit. In fact, undercoding can actually lead to an audit due to the overuse of the code you're using for your office visits. And that information comes from the e-zine articles. With medical necessity, properly documenting your patient's office visits is paramount to proper billing. The criteria for being paid for an office visit is medical necessity. If you have documented the medical necessity of the services you provide, you should have no problem being paid for the visit. If you're meeting the proper criteria for higher billing codes and you did the work, you have every right to be paid. For example, if you treated a problem and you've had the criteria present for a 99214, why would you bill for a 99212? E&M services are complex and based on several components, including the patient's medical history, medication reconciliation, and a medical decision by the physician. In the next few slides, I'm going to be discussing some of the basic components of medical documentation. Let's start with the chief complaint. When I've done audits in the past, this was a key thing that a lot of physicians left out. They weren't using an EMR, and it's critical that you must have a chief complaint when you're documenting. Patient's chief complaint gives evidence to the insurance company of why the patient sought your services. Since insurers typically are paying 70 to 80% of the bill, they are entitled to know the reason the patient came to your office and whether the services you rendered were considered appropriate. It's one of the key things that they look for. The review of systems or symptoms is a list of questions arranged by organ system designed to uncover dysfunction and disease. It can be applied in several ways. As a screening tool, asked of every patient that the clinician encounters, asked of only patients who fall into particular risk categories, for example, reserving questions designed to uncover occult disease of the prostate to men over 50, to better define the likely causes of presenting problem, as described in the HPI section. For example, these are patients with a chief concern of chest pain. They could be asked a detailed cardiac or pulmonary review of systems. So what's the best way to use a review of systems? Well, there is no review of systems gold standard. Using it as broadly applied screening tool makes the use of it following hold true. The questions asked reflect an array of common important clinical conditions. These disorders would go unrecognized if the patient wasn't specifically prompted, or the identification of these conditions then has a positive impact on morbidity, mortality. The 1997 version of Medicare's documentation guidelines for evaluation management services, it defines complete exams for 11 organ systems and significantly expands the definitions for multi-system areas. When these guidelines were released, some physicians appreciated their specificity, while many declared them too burdensome to use. There is 95 and 97. It's up to your practice whether or not which one you want to use. I'm going to discuss the multi-system exam. And with the levels of evaluation and management service, it reflects 4 levels of examination. There's a problem-focused exam, which is a limited exam of the affected body area or organ system. Expanded problem-focused exam, which is a limited exam of the affected body area or organ system or any other symptomatic related body areas or organ systems. Within the detailed exam, it's more extended of the affected body area or organ systems. And then comprehensive is basically a general multi-system exam or a complete exam of the single organ system or other symptomatic or related body areas. These body areas and systems are worth some attention. Look closely at the terms the way they're grouped. They may not correspond to exactly what you're using running through your mind when the physician is performing the exam. For example, if the physician is documenting one unit finding as HEENT or even HEENTN, including the neck as well as the head, ears, eyes, nose, and throat, note that the physician fact-finding documents for one area, the neck, and 2 organ systems, the eyes, ears, nose, mouth, and throat. One way to remember the distinction is to think in 6s. The lower level exam has fewer than 6 bulleted elements. The next level has 6 or more. The next has 12 or more, and the highest has 18 or more. Also note that the definition of the detailed exam is not as complicated as it may sound. The first alternative, at least 2 elements from each of 6 body areas, is a special case of the second. If you document 12 bulleted elements, you've documented a detailed exam, whether those 12 elements are spread evenly over 6 systems and body areas or not. The points to remember for the detailed exam are that 12 bulleted elements and at least 2 systems or body areas. If you prefer to think in terms of 6 systems and 2 bulleted points per system, fine. Just remember that this is only one possibility. When you look at this chart, note the particular wording of the requirement of the comprehensive general multi-system exam. While the guidelines say explicitly that you must perform all the elements of the exam identified by the bullets in the 9 or more systems or body areas that the physician examines, they also require that they document 2 per system or area. This distinction is evidently deliberate. I think in this rationale, the best I can understand is that the requiring of all bulleted items to be covered in the exam ensures that the physician work going to the exam is adequate enough to justify the level of reimbursement, while requiring documentation of only 2 elements somewhat relieves the physician's documentation to task. And adding on a statement of saying all other systems reviewed and are within normal limits is also a good idea. Same thing within the physical exam. Then medical decision making. Physicians must stratify the medical decision-making into one of the above levels of complexity. It's based on the nature and number of clinical problems, the amount and complexity of the data reviewed by the physician, the risk of morbidity and mortality to the patient, and the overall level of medical decision-making. It's determined by referring to this table that I have listed here for you. Some general rules of documentation. You want to avoid redundancy. Chart the description of your findings. Don't use opinion words within normal limits, intact, abnormal, etc. unless you have things to back them up. Be objective. Avoid hostility, disapproval, or moralizing comments. Basic identifying data starts the history, while a paragraph form in the general survey starts a physical exam. And never ever change a record. Use whiteout, pencil, or erase. Cross these out with a line, date, and initial. You never want to update it in this way. Make sure you cross them out and you line, date, and you initial it, or whoever is changing it. You should really have only the physician changing the documentation or whoever wrote the initial documentation. Billing E&M services should keep in mind that a new patient is one who has not received any professional services from a physician within the previous 3 years. 2 office or hospital visits are not payable for the same patient on the same day by the same physician. Administration of a drug on the same day as an office visit is not separately payable, only bill for the office visit and the drug. Medicare patients may not be charged for the completion of paperwork. And when a hospital admission following a nursing home visit occurs on the same day, only the hospital admission is covered. Next, we're going to talk about the False Claims Act. Fraud under the False Claims Act means that a contractor has knowingly presented false claims for payment to the United States. The fraud can occur whenever federal or state monies are directly or indirectly used to purchase services or goods. The Act prohibits making any false Medicare reimbursement claims. Hospitals, doctors, medical associations, lab, or equipment suppliers have often violated one of the Medicare reimbursement requirements inadvertently, thereby increasing the potential for a claim of the false claims violation. Recent federal case law requires that physicians, hospitals, and medical professionals know the legal requirements for the valid submission and collection of claims for medical services. Medical professionals who simply choose not to educate themselves may be found to have acted in deliberate ignorance or with reckless disregard and may thereby be liable under the False Claims Act. The submission of a Medicare claim by a provider is certification that they've complied with the Medicare's Act medical necessity definitions and complied with all relevant laws. And the Department of Justice stated that since 2009, some $2.3 billion has been recovered from healthcare professionals for violations of the False Claims Act. Fraud under the False Claims Act means that a contractor knowingly presented the false claims to the United States. So I put on here the liability for the Federal False Claims Act occurs and the different things that happen. Where they knowingly present or cause or presented a false or fraudulent claim for payment, knowingly makes, uses, or causes to be made or used false claim record or statement material for false or fraudulent claims. They conspire with others to commit a violation of the False Claims Act. They knowingly make, use, or cause to be made or used a false record to conceal, avoid, or decrease an obligation to pay money to the federal government. To succeed with a False Claims Act case, I thought it would be important for you to know that the government or the plaintiff must prove that, number one, there was a false or fraudulent claim. Number two, that it was presented by the defendant to the United States for payment or approval. Or number three, the knowledge of the claim was false. The damages assessed with a guilty defendant under the Act include a liability of a civil penalty of not less than $5,000 and not more than $10,000 for each violation, plus 3 times the amount of damages that the government sustains because of the violation. Because neither the Stark or anti-kickback statutes provide the rights for private action, violations of these acts are being brought under the False Claims Act. As witnessed in the False Claims Act cases, the initial punishment for the defendant, medical professionals, the cost, time, and pressure brought on by False Claims Act cases. Usually, thousands of documents and years of history are sought by the government for review. And in states where these acts are a matter of Medicaid reimbursement to the state comes into issue as well. If the federal investigators find that violations involve criminal conduct, charges of conspiracy, mail and wire fraud, money laundering, and tax code violations can follow. So once you open this can of worms, even if you're just undercoding, you're thinking, oh, I'm causing less money. If they find a pattern of undercoding, they might think there's other things going on and dig deeper into your files. One of the best ways to identify undercoding is through the use of billing analytics and benchmarking tools. Such tools, often made available by revenue cycle management solution providers, offers benchmarks that will allow you to compare your billing policies and performance against clinics in similar specialties. The benchmarks factor out geographic, practice size, and other differences to give you potential auditors a reliable comparison. Benchmark statistics delivered via a web-based service are also constantly updated in order to reflect the latest aggregated information. When judging the appropriateness of billing decisions, benchmarks can be invaluable. Not only will they help you identify potential points of departure from industry norms, but also, as long as your assignment of procedure codes is at the benchmark, any changes you make will be clearly defensible. Now, if your practice uses an EMR technology, you've added coding asset. Typically, billers require documentation in 3 areas: history, physical exam, and medical decision-making, and to assign these codes properly. The EMR systems automatically capture rendered services, including the review of systems, exam elements, and other information in bulleted form. These data not only help accurately determine proper billing codes, but they also provide a later audit trail if needed. For many physicians, the idea of a chart audit conjures up images of federal investigators or insurance company representatives descending on your offices to look for evidence of wrongdoing. For the most part, however, a chart audit is not really that scary. A chart audit is simply a tool physicians can use to check their own performance and determine how they're doing and identify areas of where they might improve. So you want to review your actual notes and audit your practice records. Look for evidence of cloning or carrying forward notes to physical exams and patient histories. Better to find these yourself than with auditors. Make sure that voice recognition transcribed notes make sense. Look for mistakes, such as this note that has found during an audit. It said her thigh was swollen shut. The physician actually meant to say his eye was swollen shut, which is a very big difference. Ultimately, however, the only way to determine whether coding is appropriate is to compare it against actual clinical documentation that you recorded in the chart. This coding audit can reveal whether any variation from national averages is due to inappropriate coding or to atypical levels of intensity among your patients. This type of audit can help make corrections before payers challenge any inappropriate coding or give you the confidence to fully code the more intense encounters that you conduct. There are a few simple rules to consider in ensuring the audit demonstrates what you intend to demonstrate. For the physician, the issues of coding are generally related to evaluation and management for family practice and internists. So this guide refers to evaluation and management auditing. Within the first step, you want to define the scope. Within a standard audit, you want to conduct these once per quarter. More frequently if you're having issues with billing and coding processes. And at a minimum, review 20 visits per provider. You want to pick a random sample. The easiest way to pick this random sample is every 4th to 5th patient off your schedule. In the targeted audit, for a specific area of concern, it's really good for reviewing E&M charges, like established patients, making sure that you have it pretty equal or you have your documentation clear if you're billing at a higher level of 99214 and 99215, or if you see a pattern of a lot of 99212 billing within your office. Again, at a minimum, you want to do 20 visits per provider. Now, in selecting the charts randomly too, you don't want to have the physicians select the charts themselves. Have the staff member pull the patient list for a week and pull every 4th or 5th chart until they reach 10 charts. Remember, you're going to do this every 6 months, so you'll do 10 charts in 6 months and then 10 more charts in another 6 months. It does not make sense to concentrate on visits that occurred over a certain period of time to observe trends. Merely pulling charts at random out of the rack will not accomplish this goal. It is virtually impossible to be unbiased when reviewing your own charts, so don't have physicians review them themselves. There should be a person in your practice chosen to review the charts, and they should have the knowledge of the coding rules, and they should be able to complete an auditing worksheet and have a strong understanding of medical terminology. That person might be another physician, a nurse, a qualified coding specialist, a medical biller, or you could even hire a consultant for this purpose. Medicare and private insurer auditors may interpret guidelines in different ways, but they usually do adhere to a few simple rules. First, they're supposed to use whichever E&M documentation guidelines are the most beneficial to the physician with auditing, either the 1995 or 1997 guidelines. In verifying your charges, you want to compare the chart to the bill charges, reviewing the patient's chart to that encounter, and check to see if the bill correctly reflects all services performed. If there are discrepancies, make note of that dollar amount. Then you want to compare the bill to the chart. Make sure that all items noted on the bill have substantiating documentation in the chart. If there are discrepancies, make note of the dollar amount there too. In distribution of E&M codes, the OIG view both undercoding and upcoding as fraud. Again, you should expect to see a distribution of claims among the 5 E&M coding levels. In medical necessity, find out if the service performed is related to the diagnosis. Also, make sure that the type of care you're providing falls within your practice standards. Physicians should be given the opportunity to review and study the results of their coding audits and to openly discuss what can be improved. Improved coding is encouraged when everyone on staff is committed to the goal of complying with documentation guidelines in order to avoid potential adverse impact on the practice. Avoid a heavy-handed response to the chart audit results. Making coding audits punitive for the parties involved does not benefit the practice and can lead to defensive behaviors that are even more harmful than simple miscoding. And completing a coding audit accomplishes very little unless a serious effort is undertaken to remedy the problems identified. Establishing an ongoing reporting and feedback system to physicians is important. Error rates should be recorded, but trends in documentation should also be noted. If one physician is not documenting a thorough history, that should be noted. If another physician is not recording a chief complaint, that should be improved. If the practice or the physician can show improvement from one quarter to the next, that is an excellent sign of a commitment to fixing errors. Remember, correcting any systematic undercoding uncovered in an audit will enable you to collect the revenue to which you're entitled, and addressing overcoding will minimize the likelihood that you'll have to pay back Medicare or another payer if audited. Basically, they just want to see improvement and that you're taking the time and that you recognize a problem and you're making corrections accordingly. The OIG has put out a report called The Coding Trends of Medicare Evaluation and Management Services, and I've included their 39-page report on the MSO website. The study is a part of an ongoing series that focuses on the rising costs of Medicare payments for E&M services in order to identify coding trends within Medicare and to monitor physicians who are at their highest coding categories. From reviewing it, you can see why it's critical that you assess and monitor trends of your E&M services, because they are paying attention. You can have a practice administrator or billing manager conduct random chart audits on a rolling basis per physician. You could bring in a coding consultant to conduct a practice-wide chart audit, or examine your top E&M codes and look for trends such as consistently undercoding or upcoding. Assess variations within your practice. Think about things like, is there a logical explanation why Dr. Black's visits seem to all be level 4 while her colleagues' codes are all distributed across the coding spectrum? More billing audits you might want to consider in your office. Unbundling. If separately billed services can also be billed under a global fee, your practice may be at risk for fraud. Confirm that the claim was submitted to the payer. Note the number of elapsed days between the appointment and the time the claim was submitted. In reviewing the explanation of benefits, make sure that the payer has considered all aspects of your claim. Review the EOB to see how it matches up and note any claims that were denied or returned for correction. Review the payments received. Make sure that co-payments were collected for each visit and that third-party payments are received. If it's a self-pay patient, make sure that the appropriate billing cycle has been initiated. Speaking of self-pay patients, I did do a WebEx on self-pay patients and how to be more proactive than reactive on self-pay accounts, as well as co-pay assist programs, if that will benefit your office. That is within this Strategies of Success WebEx series recorded a couple months ago. Additional steps that you want to take. Have the practice administrator or a consultant review the coding and chart documentation for all physicians on a regular basis. Look closely at your E&M codes for trends of under or upcoding. Use online tools to compare your groups or physicians' coding against Medicare data for other physicians in your specialty or state. And if you find that your practice is exceeding the norms, take special care to ensure documentation and medical necessity support the higher level codes, especially if the physicians are using the electronic autocoder within their electronic medical record system. It is a good idea to use an outside auditor for chart and coding audits, especially if you are short-staffed or don't have the trained resources in your office. If you need assistance from a chart audit review from an outside source, we do partner with a group that will be more than happy to help you in this area. Just let me know if you would like more information for this for your office. And right now we're focusing a lot on PQRS reporting as well. If your office is not participating in PQRS reporting and these are tied to your E&M level services, please contact me so that I can help you get compliant with this. If you do not participate in PQRS this year, your claims will be paid at a reduced rate in 2015. So please feel free to contact me and we can discuss it. So some of the next steps, if you have people in your office that could benefit from this presentation, or if you want to review previous presentations that I have, log on to the website, look under the Resource Center for the Strategies of Success WebEx series, and then all of them are listed there. You just have to click on them. They have documents, training links, and it is all recorded. I'm now opening this up to questions. Thank you so much for your participation today.